first, wish everybody, hopefully everybody's safe out there and considering everything that's going on and the news are not really, giving us any great feedback and great, information about, how this pandemic is progressing, especially in some of our states. Our cases are, just increasing. That is crazy. And hopefully everybody, do the best you can do to stay safe, stay away, and just, we'll ride this storm together. So again, and, that's just a quick message. First, I wanted to start with that. Also, I want to thank, hopefully all our medical staff, our frontline, they're probably exhausted. I do get feedback from, hospitals and things like that. And there are a lot of people that are really stressed, tired, beat. The conditions are very restricted. There's so much, stuff going on. Everybody's listening to the news, of course. You hear all the governors and the mayors of different states, the president and his team. So things are happening, but it's pretty chaotic a little bit, and the more we all contribute by staying at home and hopefully, helping that, flattening that curve, as making the statements on the news, that will help us a lot. So that being said, again, Hurricane H here. This is the iHealth channel and iHealth Radio live. And today's episode is episode 2 of MCO World, Managed Care Organizations. The first episode that we discussed in MCOs basically was just an introduction about the types of managed care organizations, who they are, what they are, how they form, what differences are, how different are they, what is the predominant version of an MCO, and we've talked about like the most common ones are HMOs, health maintenance organizations, or PPOs, preferred provider organizations, and those are the models that are pretty common out there. Today, I'm just going to give you a little bit of a guide and just an overview of how this HMO operates overall. Now, again, this is just an overview. I mean, there is so much stuff that goes behind the scenes, and but at least you'll get an opportunity to understand how this whole plays and all the different departments, how they interact with each other, how they the whole contracting piece goes, and so on and so forth, and how pretty much guiding someone through the whole experience of an HMO from the inside. I mean, everybody, gets insurance and they know that they have a product, they have, coverage, and they have, certain, co-pays and benefits that they get. But what does it take? Who is involved in the back scene, behind the, backstage, who's doing all that good stuff, to make sure that we are all healthy, under, a particular health plan. So HMO, Health Maintenance Organization, that is the most, I guess, common, form of insurance, in the managed care organizations, and basically the way it works is it's got a restricted network, and that's the first, main, differentiator between, an HMO and the other types, and so the way it works, first of all, and I guess like we said, an MCO group, a provider group, an IPA group, they can get together to form, an actual MCO, and then they basically get licensed to provide an HMO product, and then they get licensed to the Department of Insurance, through the local state. They also have to contract with the federal government, with the Center for Medicare and Medicaid Services, and get, service area coverage approval. They have to submit, a whole proposal to both state and federal, and ultimately they get approved through that process, and it's a lot of stuff that they have to present: their capacity, their marketable, or fileable network. They have to have certain number of providers per category, and specialty in a particular time frame, in a particular zip code, or in a particular county, and that's sort of those things that they have to look for. They have to have a marketing plan, they have a whole strategy, they have to have a compliance officer, they have to have the customer service presence and structure ready, the care management. They have ratios that are determined by the federal government and the states, depending on what products they sell. So if you're in Medicare or Medicaid or both, you have to satisfy all these needs, and once you meet those particular requirements, then ultimately you get granted a license, and then you get an actual contract to operate in that state, for that particular product line or that HMO product. Or maybe under the HMO you can have multiple, offerings, and each one is a plan that you would offer depending on who you're targeting and what package you're going to put together. And then, once you're operational, of course, you have to have all that stuff live and ready. So when the first member joins the plan, everything is in place. So the minute they actually enroll into that product, they have care management, they have customer service, they have transportation, whatever we promise, as an HMO, you will have to deliver, once that member becomes, live and enrolled in that particular program. And so some of the ways the HMOs actually design their format. I mean, there's different departments and different units within the actual HMO world, and each one of them has a functionality. And as I mentioned in a different series, and we talked about the quote, and we talked about leadership, but we talked about how as a team there's a like a beehive, and we all work together. Well, similarly in an HMO, just like any business, you have to have all these components, and they basically all kind of tag along and work together in synchrony, and they're synchronized. They are very in sync, and they actually have to work in harmony as well. And there's internal partnerships that have to be there, and there is a process in place for membership, from start to their life cycle within a plan until someone actually leaves, or until that company closes, their products and their doors. So a person, first of all, the HMO kind of, as I said, has to do with the network specifically, and to offer an insurance product for a health beneficiary, beneficiary or an actual member. And so when that member joins this particular plan, they'll have to have a set of things available to them. And of course, the main thing why people join an health insurance plan is really to take care of their health, right? And to really get the best, out of it, they'd have to have all the necessary services that are attached to their health. So whether it's a primary, whether it's a hospital system, whether it's laboratories, radiology labs, you name it, they have to have it. Plus, there's all the logistical stuff that may be attached to it with transportation, language needs, and so on and so forth. So people actually have to, not all the people may speak just English. I mean, a lot of HMOs have, multi-ethnic, membership and diversified membership. So therefore, there are language needs also. So the plan has to actually have all these components in place to literally deliver the best of the best of the best. And so some of the ways the HMOs are designed, they actually, as they are building their contract, and they meeting the requirements for the federal or the state, they'll have to have, a network established. And the way the network, again, in HMO works, especially in the government programs, they literally work with premiums being paid by the government to them, as opposed to in the commercial world, there are either employers or individuals contributing in terms of premiums, and then ultimately they buy those are put into a pool, and then those funds are actually managed to provide the care and the benefits. But in an HMO world, specifically if it's not a commercial space, it is an actual governmental, space or government program. It's all subsidized by the government. So if it's a Medicare plan, they get, the funds directly from the federal government. So every month, they get X dollars for each member that they have. Again, referred to as PMPM, per member per month. And if they have a Medicaid product, they'll get again a PMPM per member that they have enrolled in their plan or assigned to their plan by that state, and then they have to literally, the more members they have, the more dollars they get, and then they actually have to manage the care back to those folks. And so there's a lot of parameters that are built in place how to actually do it. So there's a lot of financial, studies, and the financial, components that get in place. There's a lot of actuary, business that goes in there to actually determine the budgets, to determine the admin costs, to determine, the risk factors and all that stuff, and then once that's designed, they know exactly how many members they need to have. They do those projections. They submit also as part of that first, submission to the government. And once again, they have all that in place, and they get, a thumbs up, and they get a start date. Usually that's the next year. So you actually in advance before you can, especially in the Medicare world, before you actually get into a state operation. And once you're in, obviously you have your sales teams, you have all the other stuff that takes place to actually start generating the business for you, and then you take, the membership through the actual process and through the actual system. And again, we said managed care delivery system, healthcare delivery system. So that's kind of like what happens. But it starts with obviously getting that application, getting that particular group, setting up this whole contract with the government if it's non-commercial product. If it's a commercial product, similarly, they just get through the Department of Insurance. They have the offerings, they have the products, they set their premiums, they get approved, and basically they have a network. Or at that point, if they're an HMO, obviously it's a network. If they're not, they have an open territory type of network. That's a different story. But today we're going to focus only on health maintenance organizations, which is basically restricting a network that typically requires a primary care physician who is actually your quote unquote gatekeeper. We don't use that word. It's a reference that we don't use any longer, at least in the sales in the health managed care type of situation. In sales, we still use it as a sales term, but not in actual healthcare term. And so that's the first rule. And then there is usually a referral. And again, some products may remove the referral, but there's a prior authorization for certain services that are key, because that's how you manage the care. As we said, it's managed care. Health plans are designed to get you as a consumer your care managed for you. As I said before, when we introduced in the senior health series and even in the MCO first chapter, first episode, we talked about that's a healthcare delivery system. You actually get into the plan. If you have Medicare or Medicare, you basically have an actual credit card for health, but there is nobody managing your health with it. So basically you can pay for things, but nobody is actually there to take and hold your arm and make sure that you actually get in the care you need when you need it, medication and so on. So your home care, your aftercare, if you're getting off hospital, your skilled nursing, your rehab, whatever you need, your home care, all that stuff, nobody's going to take care of it. All it does, it just pays for the services. And that's what the difference between your regular fee-for-service, probably Medicaid or Medicare, versus, you being actually handled by a health plan and a managed care organization. So that's the first key rule. And so now, to also provide this and build a network, there's actually a team that does that, or teams that do that, and then basically they set up these contracts with networks and providers. And these contracts vary in a lot of ways. Some of the contracts are individual contracts directly with primary doctors or specialists, which these providers have to submit their credentials, and they go through a credential process. That can take 30 to 90 days, sometimes even longer, depending on the process, what they submit, the documentation, and so on and so forth. Now, everything is good. These doctors, become part of the network and become participating providers. And there's mainly two types of contracts that they get. There's value-based, which we'll talk about in a separate chapter, and hopefully I get some guests to discuss that further. But the first one is actually what we call a capitation contract type. So basically, you're a doctor, and you come and join me as a health plan. Basically, at that point, there's a deal between us. And the way we do this is, as an HMO, we will give you some sort of an actual payment promise for services rendered. And that payment promise is also based on your membership or your patient base. So if you are a doctor as a primary, for every member that you actually have assigned to you and that you take care of as a patient, we will give you X amount of dollars per month, regardless if that member shows up or not in that particular month. So that's a capitation form. So it's per capita or per member per month. Same concept as how these plans are getting paid themselves. And then there's the other concept, which is a fee-for-service or scale type, listing. So every service, there's a list of services that the providers will actually render, and then for everyone, they'll have to bill for it. So they submit a claim, it gets processed through a claims department, and then either accepted, denied, and then it goes through the process, and they have to have code in for it. There's a whole list of codes and things like that. There's a whole unit that specializes in those things, and ultimately, when that service is rendered to a particular patient, everything goes through, and once it's paid, that goes back to the doctor gets paid, and everybody's happy, and there's no billing going to the member is happy, and so on and so forth. Now, so again, capitation per capita or per member per month, then the fee for service, which is an open, based on each service rendered. Similarly, they do the same thing with hospitals, and in the pharmacy rates. Also, there's negotiations with pharmacies about different tiers, different drugs, and then they design those things, and then these are negotiated, of course. And there are rates, sometimes, you pay a certain percentage of what Medicare pays or what Medicaid pays. And based on these negotiations, and you come to terms as an HMO and a provider, they agree, they go together, and now that particular provider becomes part of the network, and they will deliver services to their members. So it's a participant provider, and that's a health plan where the doctor participates, or the health system participates, or the pharmacy participates, or the actual lab participates, or radiology services participate, or ancillary services, whatever the case may be, vision. And that's the other thing. So they also have a network of dentists. They also have a network of vision providers, ophthalmologists or optometrists. So all these things, and some of those are based on their specialty category. Some of them are categorized differently. Some of these providers can also file in literally with and become with the plan as either a primary or specialty or specialist or both. For example, some cardiologists, especially in the senior world and the Medicare world, some cardiologists, opt to be both primary and specialist, because a lot of folks may have cardio problems and continuous a need for cardio visits and things like that. So instead of being seen as a specialty, they're seen as a primary, and their first doctor becomes their cardiologist. Just an example. And again, it could be for other specialists as well. So those are the different things that a contracting and a network unit does for the plan. Sometimes it's done internally, sometimes it's using a third party to develop these territories or these provider networks. Initially, when a plan starts, they have to have a fileable, network that is approved by the actual government, and so state and federal. And once they have that established, they have to continuously build on that. Otherwise, they will not have a marketable network. Therefore, people will not be very pleased and happy to join, particularly that helpline. So again, it's a lot of work that gets done. I mean, I'm trying to just a concise version of this, but again, going to the state, the feds, getting the contract, getting approved, getting a contract number, have met all the requirements as an actual health plan or HMO, and then once you're in it, and you have these types of contracts and you have everything ready, it's a continuous effort. Now, you have to have a marketing plan, you have to have a compliance strategy, you have to have, the whole process in place. Your care management program is in place. You have to have all the different pieces. And I want to go through some of these departments, and list them up, and then also kind of give an idea of how they all operate. Some of them are very common and across all businesses, but they are necessary. So HMOs are just like another business. They do have, the whole need for everything, plus everything that is care, need. So they have, from the beginning to the end, from an HR department with their components, benefits, recruiting, personnel relations, and to your customer service department, and to your provider department and network development department, to your marketing and sales department, to your community engagement or community relations department, to your events department. And some of these departments can tie in with each other or report to the same hierarchies. But so they exist, as different units. Each one of them, again, has to deliver a certain service, within the actual chain of operations. So they all contribute to the successful operation from the moment a member joins, or all the members join, to the minute that these members decide to leave, or they pass on, or they just basically stay as long as they're healthy and willing. So again, HR, finance department, big, unit. I mean, they have different accounts payable stuff, because obviously it's an operation. There's money that is coming from the state. There is all that's the premiums. There's payments out, for services, for claims. There's payments for platforms, technology that the plan uses, and things like that. So they have also to have a structure, an actual platform or platforms that they have to use to provide these services, whether it's a CRM for the customer service care, units, for provider relations and handling providers, a claim system, and different types of other systems internally. There's also a must-have, for all HMOs, a compliance officer component, or a compliance office. Those are the folks that actually make sure that everything is compliant and regulatory and meets the actual the demand of the state or the government or the federal, government. And they're basically the ones who actually do the auditing, the internal auditing. They do the checks and balances to make sure everything is operational. And they're the ones who will probably, as a unit, get audited by the government. And that's the other thing. The government will require some auditing, and will eventually audit all these plans. And they'll just do a full run on all the operations, their policies, their procedures, their processes, how they handle certain things, and they test everything from finances to claims. And they look at caseload They look at, how they were handling, grievance and appeals, and we'll talk about that in a minute. All that stuff, can get audited, and so the compliance department has people within that unit that does all that. Then also there's within the compliance world, sometimes it's also under the legal, counsel. They might have also an SIU unit, special investigation unit, to see, to check for fraud, waste, and abuse, and also any investigative things that they have to do in the event that something. So it's really, if you're a consumer, this is really very, very, hopefully it will give you a clarity on how your health is actually designed in the back, and how much it takes to actually really put a plan in front of you, and, with an offering. And there's also the biggest piece, obviously, in an HMO is your care, and the healthcare piece is it, right? Again, healthcare delivery system, managing your care. This is not just paying for your care, managing it as well. So, and again, if for professionals that are listening to this, or if you're new to the HMO world and you just need to learn a little bit more how it operates, this could be a good place to start, and it could be something that is valuable to you to learn about this process. And of course, if you join the plan, you'll probably learn these as you're part of it and participate. But just to give you a little bit of the whole, operation and how it all, works. So again, there's obviously, as a plan, and even there's a management or leadership, hierarchy, but there's also a reporting structure from the plan to like the board, which is typical for all businesses. And some of these folks, some of these HMOs can be for profit, not for profit, irrelevant, but there's always a board that actually going to be, to have the fiduciary, responsibility, and basically be responsible for the actions of this health plan. And then, they ultimately make the decisions, and, the financial, viability of the plan is in their hands to make sure that, the plan is working. Like I said, whether they're for profit or not for profit, everybody makes, they're in the business to actually make some kind of money. The difference is, if they're not for profit, that surplus is called surplus, is being reinvested back in the care and going back to benefits for the next year, and so on and so forth. If they do have an actual for-profit structure, then that goes typically, a percentage goes to their, shareholders, or dividend, are paid to the ownership. And then that's how it applies. But the way it works, all the revenue that is generated and the way it's designed financially, typically more than, I would say 90% of that is actually for the care, and maybe a 10% or less is designed, to be taking care of all the admin costs. So everything that operates under an HMO world, would probably be under the admin cost of a 10% of all that, monthly premium that they generate or collect from the government for how many members they have. And they have to manage with that, properly, and benefits and stuff. And then the rest of it is all the care. So it's all your, bills, claims, and things like that for you as a consumer when you actually go to the hospital, you go to the doctor, your prescription drugs, all the stuff that is, that you're entitled to. So again, financially, there's a lot of stuff that goes behind the scenes, and everything is based on, really, like, there's a lot of actuary work it's in the back, and they do a whole study of all the different risks and things like that. And they assess, what's the best way, what's the benefit like, which benefit is going to do this and the other, and then as the benefits are being designed, everybody and all the different teams get together, typically to actually present. So you have the sales unit, you have the actual care management unit, you have the other operations unit to make sure that they can handle the flows, they can handle all those new benefits or services that are being put on the table to offer to you as a consumer. So a lot of work gets done. That in the Medicare world, that process takes maybe more than 6 months just to get every year. Starts sometimes early January, ends around the last week of May, and it gets filed in the first Monday of June, and to the CMS, the federal government. So a lot of work gets done. There's different levels, and every year there's different restrictions. There's different things. There's also the like in the Medicare world, we have the STARS units, or the STARS department, that is actually specifically working just to make sure that all the plan is meeting all the different measures that the government is setting for the plan to meet a certain star category. And so again, there's a lot of analysis. There's a lot of work in the back end to help you and make sure that they deliver the best care that they can give you. So again, a member begins, and I'll guide you through the actual cycle of a member. But so other departments that are as key, like I said, legal, obviously all the contracting. I mean, health plans do have a lot of contracts with providers, with vendors. There's a whole unit actually that runs that, and usually that unit, runs up into a legal unit, or at least works with the legal department and legal counsel. But so procurement type, units actually have that. Vendor management units sometimes are designed to be doing that. And there's also project managers that actually handle different projects at any given day, at any given time. So the operation is really not very light. It's not like five people running this show. It's a big operation. IT department runs a lot of different pieces from making sure that the technology is working, make sure that the actual support systems are there, make sure that telecom is working, the phone systems are working, the call center is working, because again, CMS, and or the state, they would be doing a lot of auditing and a lot of checking, and that can be done across the whole contract year. And of course, these are yearly contracts, so the government can actually shut down a plan if they want to. So everything has to be done in due measures, in exact way, and the plans go beyond the Call of Duty to try to make it happen. Is it easy? No. It's a lot of work, and a lot of people really behind the scenes are making your care, what it is, and they're working, literally every day to make sure that you, as a consumer, get the best, that you need, so you can get the best health care and ultimately stay healthy, happy, and live, the happiest and the longest. So it's very important to understand all these components. So again, these are all the different things, and then you have care management. There's medical, staff that is usually in a health plan, and they do different things from prior authorizations to looking at, drugs, to looking with the pharmacy department, of course, and looking at, case loads and working with different, cases and members that may have some ongoing issues or medical, issues that they have to actually take care of. Some people, you have to actually have home health, time and hour based on the type of plan that they have. They'll have to be assigned certain things. They have to manage the home care, scheduling, things like that. So there's a lot of, technical work that gets done behind the scenes with some super people, and really caring, and their main task and the main job, they actually wake up every day in the morning to go to their work and fight, so each one of us out there, as consumers, get the best care that, now, as a consumer, you have a lot of variety of plans and a lot of different choices, but at the end of the day, understand that, we all want everything we want, and we dream of and things like that. It's not as easy as it is, because plans can give you the best that they can based on what they have and what's available to them. And so again, it all depends also on the size of a plan. If a plan is a very small plan, they have very little membership, it's very difficult to actually operate at the same scale for a larger company or national company. So you have community plans and you have national plans. Each one of them may have different capacities. Also, some small plans may not have the same, budgets ultimately to run, campaigns and things like that. So they may not have the same presence that someone would see with a national, provider or carrier. So these are things that, just to consider, just because a plan is small doesn't mean they cannot deliver. Sometimes actually small plans can deliver just as good or better because they actually have, a team that is dedicated. They're not too big. They're not all over the place. They actually have an actual tight, ship, but that doesn't mean, again, big companies have just as that. They have the experience, they have the expertise. So it all depends. But the idea is you cannot undermine a small plan or a big plan. It's not about the size of the plans. It's just about what they can deliver. And each plan that gets approved to actually provide care and provide these services under the HMO world, will be approved. And once they met all these requirements. And again, trust me, this is not an easy thing. And so again, there's a sales department, with all its components. There's a marketing components, and all these are very heavily regulated. There's licensing requirements, as we talked in different series and chapters. There is trainings and there is auditing, there's processes in place, there's scripts that are very, scrutinized and they have to be in place. Your customer service department is a 24/7 operation. For the most part, they have, call hours, and even after, certain, hour day, there's like a backup, hotlines. There's some of these plans, most of them actually have some sort of a nursing hotline if something, God forbid, happens at night, which basically, would prevent you from going to an emergency room, which no one wants to go to. So if you really feel like, you get into a point where you have a pain or something at night that you're not sure about, you can actually go in and dial into this hotline, and you get a live nurse or NP, nurse practitioner that can, sometimes even they have deals. Some plans may even have deals with doctors on call, and you'll get the ability to actually interact with someone just like a telehealth type, but on the phone. Some new technology, some of them even have technology where it's really visual, telehealth, 24/7 type, or at least over 9 hours. And then as you talk to these folks, you'll be able to triage you. They'll identify some of the needs. If there is any urgent matter, they'll actually ship you and call in for 911 for you to go to the ER. And if they can prevent that by giving you some guidance and helping you go through the night and hopefully see your provider in the first thing in the morning, they will do that. So those are all the different things. And again, there are services also that some of these plans will provide you. So transportation, logistics, mail orders, things like that. So they have to handle this. There's also departments that are such as the pharmacy department. They actually work with the pharmacy networks, with the providers, the PBMs, or the actual pharmacy benefit management companies that actually help provide you with all your prescriptions at the pharmacy when you go and swipe a card. They're the ones who actually handle that transaction in the back end. And so those are all things that operate in the back. So it's a lot of intricate. So again, I'm trying to simplify it, and there's hopefully I'm doing a good job about breaking it down to simple words and making it. But it's really just the picture is larger. And it doesn't matter, again, what size of the plan. These things all plans must have. So if you want to be a health plan, if someone, an MCO wants to build, or provider network wants to build an MCO concept and create an HM of their own, they'll have to go through this whole scrutiny, the whole process, have a structure that is sound, and everything is actually being, it gets proposed to the state or the feds, and then it gets reviewed. Once they meet all the criteria and they get approved for that next season, they get a license. And then they get monitored across a period of time, and frequently, and then every couple of years they get an audit inquiry, and then basically the government shows up and they do reviews of all the files and things like that. So again, all these different components. There's also an enrollment unit, which is because you actually, as a member, you join, so your sales division or your sales agents, basically enroll you in the plan. They convince you, you're happy, you're great, you like what you hear, you join the plan. But what's next? So now that process, the application goes through the process. It goes from, submission, it gets handled by the enrollment unit. They scrub those applications, they review them for eligibility, make sure everything is good based on the requirements of the government. And because remember, these are all government agencies and they're regulated and they get paid and subsidized directly, so it's not free. So I've had this question before, people's like, well, is it free? No, nothing is free, obviously. So somebody is paying for the care. It just, as we said before, in the world of MCOs or MCO world, the government, contracts with private entities to actually pay for the care, and they know exactly how much they pay in per each member for every month that member is actually, or beneficiary is on that plan. And so they actually control the cost. But at the same time, they have to control the process and have the measures in place to actually make sure that, you as a member get the best that you can. So again, application gets submitted, gets through the process, then it gets submitted to the Center for Medicare and Medicaid Services. For their Medicaid, they check also eligibility for Medicaid, make sure that the two eligibilities are there, or depending on which plan they have, that they are eligible for that particular product and program. And then, that application gets, created or approved by the government, it gets submitted back, and then that person becomes an effective member in whatever that effective month. So it could be the next first of the month, it could be a couple of months later, depending on the time frame that you enroll and what you enroll for. And then once you become a member, typically there's a whole process that happens. So you get a welcome kit. So there's a time frame as to when you get those kits, available to you. You get your provider directory, so you can get to select doctors. Of course, when you enroll and with your agents, you get to select your primary. Again, we are an HMO, concept here. We're talking about just HMOs. So you have to select an actual primary care physician. And if you don't, it gets assigned to you, and they have the ability to change that later on if you could not make up your mind at the time you enroll. But at the end of the day, you need to actually start with that. And you have to understand that when you get into a network, you cannot get out of the network. So you cannot just go to any doctors you want. They have to be in a network. And if they're specialty services, you have to go first to your primary, because sometimes, I feel like I want to see, I don't know, a dermatologist, but I might just go to my primary doctor and they can just prescribe me an ointment and I'm good. So you always start with your primary to see that, to make sure that they see everything about you, they know about you, and so if they feel that you need to go to specialist, they will actually give you a script and a referral, and then that goes authorized, and you go to see your specialist. And also, that specialist will communicate back with the primary, so you have all the recording. The primary will have all your records, and ultimately, they know what's happening to you, what medicine you're on, so they will treat you and keep your health, at the best potential, possible. So it's important to understand those things. So it's not just like, I'm going to be an HMO, I'm restricted. Of course, you do not want to be an HMO if you want to go everywhere. But the idea, if most of these HMOs have decent, good networks, that all your providers typically will be there. So, and again, agents' jobs is to actually identify all your providers up front and make sure that they verify that your doctors are on board, that in the network, and that your prescriptions, drugs are covered. And then once you establish that, then you go into the enrollment phase and you accept the enrollment and you join the plan. At that point, you just follow through. You go to your doctor. Your primary is your source, your main keeper, the main entity that you have to actually have a good relationship with. And frankly, people do this all the time. They establish a good relationship with their primary docs and they stay with them for longest. Okay, it's very difficult to move someone from a primary care doctor that they've been happy with for years, right? So again, but that relationship is everything. That's what we encourage in managed care. As I said in one of the sessions, you join managed care not because you're going to get luck, it's because you're going to have a team that is caring for you. And that team is going to help you go through like all the stuff. And sometimes you don't know what to do, how to operate when something goes wrong. And if your caregivers are watching, or if you're a caregiver, you want to understand all this because it's important for you to understand all these processes and who's available for you. So there are care managers out there. There is some companies even have social components and social units that help with social services. Some even go to the extent of helping with bills and things like that. So that's not the primary role for health plans, but some of these plans go beyond the call of duty to make sure that you have all. And even the government now is really enforcing, or at least encouraging, some of these social determinants that impact people's health, mental state, and all that. And a lot of plans are getting into it to try to help the folks get in the best way that they're possible, so nothing affects them. Because at the end of the day, if they're worried about paying a bill, they may not be able to go to a doctor or get a prescription. So which one do I have to pay for? And sometimes we don't want that. So as an HMO, those are things that are taken in consideration to help ultimately the consumers get the best. And so again, they do all this. So enrollment comes in, application get processed, then you get assigned a care manager. So depending on your scale, there's also what we call typically a health risk assessment. So basically there's a survey that most of the plans will send you or do after you become a member, to identify any of your needs, health needs, any conditions that you might already have. Not because they're not going to want, you're already in the plan. So there's no cherry picking with government programs. You get in the plan, they're going to have you on the plan unless you are restricted by the government as a category that's not going to be eligible for the managed care piece. You're in the plan. No one can stop you. So when you're in the plan, now the plan's rule is to understand your needs, your health needs. They assess you. They understand what the best way to actually take care of you and make sure that you stay healthy or get healthier. And so then you get a care manager, and depending on your level of need, they'll give you they'll get there's a pool of people. So some people may be healthy, so they may not be in the first rate in terms of like who gets the first assignment. But that's being always evaluated, and so the nurses will actually be doing that. There's a medical director, or sometimes multiple medical directors in a plan to also talk about these things. Also, there are care managers that actually working with the providers to make sure that when the claims come in and authorizations are required, that these things are needed. Because again, a doctor may prescribe something that the nurse may, or the actual care manager may feel like, wait a minute. And these care managers are typically nurses, so they actually know the stuff, and they're actually at a higher grade nurse level and experience, so they understand all these things. And sometimes if they can't, they go to the medical doctors, who are actually true like regular doctors within the plan. And so that's the medical expertise team that actually kind of handles the care, whether it's regarding surgery, an extra type of radiology screening or some sort of lab work that you need to get, that team will actually determine, is it needed, is it not needed, maybe there's more. And they really care, as I said in a different session, they really care. And they will go beyond the call of duty to make sure that their members are getting the services they need. They fight for the members. They want to make sure that everybody gets what they need, they get the services, they get the authorization. Things can get denied, and they only get denied because they're not needed, and because, just because I feel like I want to be seen by, an eye doctor when, I'm not needing any eyeglasses, whatever, that may be a question. But again, I'm not the clinician here. So I'm not going to tell you, which conditions specifically gets, denied or not. But case by case, when, those claims come in from providers, they can be overbilled, underbilled, whatever the case may be, or they prescribe something that is not, in the best, shape, form for the care status, and there may be a new provider, they don't know your history, so the care managers know this, they interact with them. Also, these are the same, teams that actually will work with someone if they get, God forbid, hospitalized, and they work a discharge, process, they work, a plan for them, they'll get them into rehab if needed, they'll go beyond that and schedule some home care for them if they needed some assistance at home while they're, recovering. So all that stuff gets in place. And so those teams are really working, for the purposes to make sure your health as a consumer is at the highest level. And again, across all health plans, this is the same structure. So yes, there is difference between plans in terms of benefits, maybe the look, this, that, the other, and maybe some networks are different. But really, at the end of the day, the concept is the same. All plans have the same requirements they have to meet in order for them to actually operate in any state, of our nation. And, when they operate, they got to meet these credentials, they have to meet these requirements, and they have to be audited and have to actually, cross their T's, dot their I's, and make sure everything is done 100%, 200%, for you. So as a consumer, you can rest assured that you're, being taken good care of. Now, again, sometimes, there is a decision that is made that may not be appealing to a consumer, and that's why every consumer within a health plan and HMO, and actually a lot of these things are exactly the same in the PPO. The main difference will be the network, and the access to providers outside of network. But other than that, they're similarly in terms of the whole process. So we don't even have to have a new session for PPOs. It's the same concept, with the exception that you can go to multiple, doctors and providers out there. Wow, time flies. So that being said, that's really what the actual process, looks like. That's how actually it works. And, you as a consumer will get the best experience by joining an actual, HMO or a PPO if you need to. But at the end of the day, it's actually more beneficial to actually have a team that's going to help you. And this particular session was more about just giving you an idea of what it takes, for a helpline to actually be in place. So the consumers, whether they have Medicaid, Medicare, or both, or even in the commercial, world, they have, teams that are out there with expertise, and they are actually protected. They have also rights for grievance and appeals. There's something you don't like about a particular decision, you can appeal it. If you don't like a service, you can grieve it. And, there's a lot of processes in place, and there are teams also, grievance and appeals departments, that are just specialized on those things. So if you're not happy, you get to, gets reevaluated, and you get a response, within a certain time frame, and then ultimately you get the best that you need to do. That being said, I think the time is up. We're coming to the end of the 45 minutes here. I just slotted, 45 minutes for this particular, show. I should have put more time. I apologize. Again, thanks for watching the iHealth channel and listening on the iHealth radio. This is your host, Hurricane H. Thank you, and have a great night. Stay safe out there and stay healthy.